Hello, everyone. My name is Ted Imbery. I'm one of the neurotologists at the University of Chicago, and it's my pleasure to be coming to you virtually to discuss otologic care of the craniofacial patient as part of this year's audiology symposium. I have no relevant disclosures, and here are the learning objectives for our talk. We're going to understand the otologic manifestations of cleft palate and review hearing rehabilitation options. We'll shift focus a little bit and then discuss some options for patients with congenital aural atresia. And finally, we'll appreciate the importance of multidisciplinary care for these complex patients. The management of children with craniofacial abnormalities is challenging, and it really is best served by a team approach. There's audiology, speech and language pathology, ENT, plastic surgery, social work, and dentists typically involved. But seeing these kids achieve success into adulthood is very rewarding in the long term. Here's an example protocol for some of the care that occurs for these patients with cleft lip and palate as they get into adulthood. Otologic care is an important component of the team. The majority of these patients will have conductive hearing loss as well as speech and language developmental issues. Some patients with syndromic etiologies may have sensorineural hearing loss. The table here highlights some of the common syndromes that may be seen as part of a cleft and craniofacial team, with the typical hearing loss profile on the far right. For the sake of the presentation today, we're not going to go through each of these syndromes individually. Instead, we'll really try to focus on cleft palate here for the beginning of the talk. So cleft lip can occur in isolation and typically has no hearing loss. Cleft palate, on the other hand, can occur with cleft lip or in isolation, and these patients typically have a lot of problems with otologic disease and other speech and language developmental issues. They usually have dental deformities as well as other issues with facial growth and psychosocial issues. Cleft lip and palate is the most common congenital abnormality of the head and neck. Cleft lip is a little bit more common, occurring in about 1 in 1,000 births in America. Cleft palate occurs in about 1 in 2,000 births. Interestingly, cleft lip has a higher incidence among Native Americans as well as Asians, with a lower incidence among Caucasians and African Americans. By contrast, the incidence of cleft palate does not really differ among ethnic groups. Cleft lip does seem to be a little bit more common in boys compared to girls, and cleft palate is opposite, with girls being a little bit more common than boys. So how does clefting of the palate result in otologic disease? There are numerous abnormalities that occur around the cartilage and muscles surrounding the eustachian tube. In particular, we see hypoplasia of the lateral cartilage relative to the medial cartilage. There's an abnormal curvature of the eustachian tube lumen. There's different width and angulation of the skull base with respect to the eustachian tube. And as well, there's abnormal insertions of the tensor villi palatini and the levator villi palatini as they insert into the cartilage. In some of these patients, there's actually no insertion of the TVP muscle itself into the lateral cartilage. Here you see a cross-section schematic looking at the orientation of the eustachian tube and the insertion of the TVP as it kind of comes around the pterygoid hamulus. This picture just highlights that a little bit more closely. And again, in a lot of these kids, there will either be abnormal or no insertion of the TVP onto the eustachian tube cartilage. What happens with this anatomic dysfunction of the palatal muscles is dilatory eustachian tube dysfunction, and there's going to be near ubiquitous otitis media with diffusion and associated conductive hearing loss. Again, sensorineural hearing loss is rare and may be more common in those that have syndromic etiology with their clefting. A lot of these kids then will have fluid and chronic otitis media as a result. Conductive hearing loss can have a profound effect on development. In children who have eustachian tube dysfunction and otitis media without cleft palate, this tends to improve by the time they're around 4 to 5 years old. But patients with cleft palate have been found to have issues well into their teenage years. In some kids, there may be some improvement after repair of the cleft palate, and this may somewhat depend on the technique of repair. In general, though, pressure equalization or ear tubes remain the mainstay of treatment. There's some controversy around this in terms of when to do it, being early or late, how aggressive to be as well. Chronic fluid and ear tubes do lead to some problems down the road. You can see scarring or laryngosclerosis, residual tympanic membrane perforation, as well as other ossicular abnormalities or even cholesteatoma. So the long-term management, as well as the timing of intervention for otitis media with effusion and its complications, is debated. Some centers advocate for a conservative approach, trying to utilize fewer ear tubes and thus hopefully decrease the risk of complications such as cholesteatoma or eardrum perforation. And instead, then they may just simply offer amplification to overcome the conductive hearing loss. A more aggressive approach tends to use ear tubes more prophylactically or more frequently, regardless of fluid. There are different types of tubes that can be used either for the short-term or long-term management. Here's some data that I was part of during my residency training that looks at the long-term otologic results for patients with cleft lip and palate. 353 patients were studied retrospectively, and all of them underwent some form of cleft palate repair. At our institution, we placed ear tubes at the time of surgery, even if there was no effusion present. Below, you can see the breakdown for isolated cleft palate, bilateral cleft lip and palate, and unilateral cleft lip and palate. As well on the right, the breakdown between those who had a syndrome versus no syndrome. Here are some of the otologic complications that occurred, with perforation and laryngosclerosis being relatively common in a lot of these kids. But interestingly, there was a low rate of cholesteatoma and other ossicular abnormalities. In terms of ear tubes, there was about an average of 2 to 3 sets of ear tubes for these children, which really didn't differ based on the type of palatal clefting or whether or not they had a syndrome. Looking at tympanometry as an indicator of middle ear function, you can see that abnormal tympanometry is evidenced by a type B tympanometry tracing, oftentimes will persist well into adolescence or their teenage years. The number at the top in parentheses is a large or open volume, so indicating that they either had a patent ear tube or perforation at the time of testing. Looking at the air-bone gap trends with age amongst the different types of palatal clefting groups, we see that there tends to be a persistent conductive loss that does go into the teenage years. So what about these kids that do have residual perforations or other abnormalities? So looking at patch laryngoplasty, 15 patients in our group underwent patch laryngoplasty with a success rate of about 60%. Underlay tympanoplasty was performed in 9 patients with a higher success rate of almost 90%, and the majority of these patients benefited from using cartilage for reconstruction. In summary, looking at the long-term care of these patients with cleft palate, the otologic sequelae often will persist well into adolescence. Middle ear dysfunction can persist as abnormal tympanometry or persistent conductive hearing loss, as we saw indicated by the air-bone gap. Prophylactic placement of ear tubes does not appear to increase cholesteatoma incidence. Again, in our center, we typically put in ear tubes at the time of palatal repair, whether or not there was fluid, and when the tubes came out, typically replaced them pretty quickly. For patients that do have residual perforations or other ossicular abnormalities, tympanoplasty can achieve similar closure rates as their peers, but there's always some controversy as to when to do this and what kind of materials should be used. In general, I would advocate for using cartilage, which tends to provide a more robust repair. As well, if possible, waiting until they're a little bit older. It makes the surgery a little bit easier as well. There's overall need for close monitoring and treatment of middle ear disease in these patients with cleft palate. Again, to summarize, we tended to place ear tubes at the time of palatal repair, which usually would occur around the age of 9 months. We would replace if there is a recurrent effusion, and typically when replacing the tubes, we would use a T-tube, which would be thought to be a longer lasting tube. There may be a higher rate of perforation with the use of T-tubes, but again, tympanoplasty surgery can be successful in these patients. As well, I advocate for treating concomitant allergies and other sinus problems, as that will even further hinder the normal function of the eustachian tube. These patients need frequent hearing checks, and there may be some potential role in the future for using adjuvant techniques such as eustachian tube balloon dilation. So shifting focus to aural atresia. Aural atresia is a little bit more rare compared to cleft palate, and congenital aural atresia occurs in about 1 in every 10,000 to 20,000 births. Unilateral is much more common than bilateral, And interestingly, the right ear seems to be more commonly affected than the left. The incidence is higher in males, and in about 10% of cases, it's associated with a recognizable syndrome, such as Treacher-Collins, Goldenhar, or hemifacial microsomia. In about 5% of the non-syndromic cases, there is maybe some inherited form of this. Here are some of the common syndromes that you'll see associated with congenital aural atresia. So Goldenhar or hemifacial microsomia on the left and Treacher-Collins on the right. And these are all pretty recognizable facies. Congenital aural atresia almost always occurs with some degree of microtia. So microtia is an abnormality in the development of the outer ear. And there's a grading scale used to describe this, with grade 1 being a essentially normal but just smaller ear, and all the way down to grade 4, which is complete absence of the ear. Grade 3 is oftentimes referred to as a peanut ear. And grade 2, there's a little bit more abnormality, but there's still sort of a basic architecture of the outer ear present. There's a lot of controversy surrounding management of congenital aural atresia. In particular, what kind of interventions should we do? For kids that are going to consider surgery, we oftentimes will get a CT scan to determine candidacy, and so there's some controversy about when to do that. As well, what's the role of amplification, in particular for those who have unilateral congenital aural atresia? There's multiple types of amplification that can be utilized, from bone conductors that can be worn on a soft band, or other newer devices such as the Med-L Adhere, which uses a sort of a sticker to stay on. There are the Bahas, the Connect, as well as the Track, and the Oticon Ponto, and then newer devices such as the Med-L Bone Bridge and the cochlear ossia. And then there's even the option for a canal surgery. So it can sometimes be kind of hard to figure out which is the best option and when to do it. So in terms of investigating the hearing, obviously these children should get a formal ABR within the first 3 to 6 months of birth. It's important to not overlook the contralateral normal ear in unilateral cases and perform OAEs and do sound field audiograms or VRA in a toddler. Once they're old enough, you want to be able to do mass bone conduction thresholds for the atretic ear. It's important to note that developmentally, the inner ear develops earlier than the outer ear and the ear canal. So most have normal cochlear function, and typically they're going to have just isolated conductive hearing loss. As you may know, there's going to be a masking dilemma in bilateral atresia cases. This can be overcome by doing an ABR or a unique test called the sensory neural acuity level, the SAO. So this is a special masking procedure where air conduction thresholds are going to be compared in the presence of a masking delivered via bone conduction. A larger shift would indicate that the hearing loss is conductive, and little or no shift indicates sensory neural hearing loss. In terms of hearing rehabilitation options, there's obviously the option for observation with monitoring and helping the child get preferential seating in class with an IEP or utilizing an FM system. Again, none of these are invasive. There are percutaneous bone conduction devices, the Baha Connect, which uses a post, as well as the Ponto, and these we tend to think deliver better sound quality because you don't have any attenuation from the skin. But obviously being percutaneous, there's going to be some degree of maintenance that's required to help keep the surrounding skin clean and healthy. And so some of these patients will have issues with infection or drainage and other issues around the abutment. So there's also then transcutaneous passive processors, the Baha Attract. And there's always the problem, certainly for active kids, sometimes these things have a hard time staying on. And there's also some degree of soft tissue attenuation, through the skin. And so sometimes the fidelity and the higher frequencies is not as good with these. The two newer devices, the Med-L Bone Bridge and cochlear ossia, are kind of the best of both worlds. Cosmetically, they're transcutaneous and utilize a magnet system, as well as other piezoelectric technology that help with sound fidelity. The problem with these devices is that they're not FDA approved until 12 years of age. So if you're considering these devices for a younger child with aural atresia, potentially would have to use another device initially, or just wait until they're a little bit older. So the management of unilateral aural atresia in particular is controversial. Obviously, it goes without saying that amplification is needed for bilateral cases. But should we be putting bone conduction devices on all children with unilateral atresia? Here are some of the pros and cons of amplification in unilateral aural atresia. So obviously, the benefit is that there's going to be stimulation of the atretic ear and cochlea and help formation and development of the central auditory pathways. And this will support speech and language development. And as you know, then it overcomes the head shadow effect. Cons would include some issues potentially with device cost, as well as comfort and compliance of wearing it, and then cosmesis. There's some evidence to suggest that sound localization and the overall benefit in noise may not be as good as we thought. So does bone conduction really help sound localization, hearing, and noise for these unilateral cases? There's some data here that I've indicated below. So patients with unilateral conductive hearing loss show no difference in sound localization in the aided versus unaided conditions. In children with unilateral conductive hearing loss, a hearing aid did help somewhat with hearing and noise, but didn't particularly improve sound localization. And another study found no improvement in objective measures, but some of subjective improvement. A study by Kessler et al. In 2013 surveyed unilateral atresia patients in comparison to those who had a unilateral sensorineural hearing loss. The goal of the study was to look at differences in terms of academic difficulty as well as resource utilization for these patients and families. It was a survey study, so there were only 40 responses ultimately in the unilateral atresia versus 11 in the unilateral sensorineural hearing loss. Unilateral congenital aural atresia patients were less likely to repeat a grade, but still utilize a similar amount of resources compared to those with unilateral sensorineural hearing loss. So whether a child with unilateral congenital aural atresia should be amplified with bone conduction devices remains a challenging question. Here's some of the data from that study. So again, the biggest difference, though only was a difference of 2 patients, was whether or not a grade was repeated. You can see in terms of resource utilization, speech therapy, IEP, and FM utilization, a similar degree between those who had the unilateral atresia versus unilateral sensorineural hearing loss. It's also important to note that because of the associated cosmetic deformity, typically, some degree of microtia, the hearing deficit in these children is going to be identified earlier. And so because of the earlier evaluation, oftentimes these children can obtain more timely resources and intervention than those with unilateral sensorineural hearing loss. This cosmetic deformity is oftentimes a constant reminder of the sort of underlying functional disability that that ear has. And so in some regards, at least the families that have children with unilateral congenital aural atresia may be a little bit more motivated to do something. And oftentimes we think of unilateral sensorineural hearing loss as more of a kind of quote unquote silent disability. And so maybe these families are not as compulsive about resource utilization or seeking out assistance. So just a couple things to point out, kind of looking at that study. Still, in general, if you look at data from this survey, few of the families with congenital aural atresia ultimately ended up using bone conduction devices. So do these children require binaural hearing or better hearing and noise and the ability to localize sound with amplification? So the evidence is somewhat equivocal. In adults who have unilateral conductive hearing loss, there's better sound localization with the BAHA compared to single-sided deafness adults who use a BAHA, and that seems pretty obvious. Pediatric unilateral conductive hearing loss patients show no difference in sound localization in the aided versus unaided conditions. And pediatric unilateral conductive hearing loss, those who utilize some degree of hearing, some form of a hearing aid or amplification help somewhat with hearing and noise, but did not improve sound localization in particular. And you see the cited studies there at the bottom. So overall, the decision to amplify in unilateral congenital aural atresia is very personal. I will never discourage a family from considering it and certainly try to support and encourage their desire to try it. Obviously, you want to continue to monitor the hearing and academic progress of these children and make sure that they get the needed support for speech and language development. In general, if you get a child to try a bone conduction device or other hearing device earlier, there's usually going to be better adoption later on. So what about the option of aural atresia surgery? Congenital aural atresia surgery is challenging, but it can be an option for select patients. The decision for surgery in these patients is complex, and there's a variety of factors to consider. In particular, they have to have favorable anatomy, and this is where the CT scan comes in to determine whether or not they're a candidate. You also have to factor in the age and maturity of the patient, the goals of the family, as well as plans for microtia repair. So, majority of these patients, whether or not they're going to do canal surgery, oftentimes will elect to have some degree of cosmetic repair of the associated microtia, and this needs to be correlated or coordinated with the plastic surgeon. And the degree of hearing loss is also important. So, children that have a sensory neural component are typically not considered for atresia surgery. As I said, imaging is indicated if a family is going to consider canal surgery. And at the earliest I do this is about 5 to 6 years. So there's really no need to do this immediately after they're born. But if you or anyone else notices that there's not complete canal atresia, and if there's actually a canal stenosis or some rudimentary pinpoint canal, there is the possibility that these patients may be at high risk of developing a canal cholesteatoma. So typically in my practice, I would image these children a bit earlier than just a standard complete atresia. The CT scan here at the bottom just kind of illustrates this. And so on the right ear, you can see that there's a complete bony atresia. And on the left side, you can see there is sort of a rudimentary canal. And one of the things you have to watch is sort of the, is there any development of a cholesteatoma immediately there, essentially trapped skin that can't migrate out. So when we do a CAT scan in these patients, we look at a variety of anatomical things to determine success. And the sort of tried and true measure of this is the Jarsdorfer score, the J score. And there's a total of 10 points. So essentially you look at the CAT scan and you see if these various anatomic things are present. They all have a point, with stapes being the most important, getting 2 points. And you sort of add this up to get an overall score, and that kind of helps determine their candidacy. And there's been a variety of data that looks at this, but the J score in general will correlate with the postoperative results. So on the left there, you see patients that were operated on that had a lower grade of 5 to 6, compared to those that had 7 or higher. And you can see in general, the average air conduction pure tone average was much better in those that had a higher score. And it makes sense. Again, the higher score, it means that there's more favorable anatomy. And so the surgery is then technically easier. What about results in the long term? So you can see on this bar graph here at the left are the initial preoperative results. And again, most of these children will have a maximum conductive hearing loss, so a PTA of around 60. Initially after surgery, a lot of these kids with a good result are going to get down to about 30 or so. You can kind of see the trends over subsequent years of follow-up, despite some dropout. The pure tone average will oftentimes rise a fair amount. So what is the optimal time to operate? There's no sort of set answer to this, but typically I would wait till about 6 or 7 years of age, occasionally 5 if the child is a little bit bigger or more mature. One of the things you want to consider again is the radiation dose for a CAT scan. There's really little need to do this when they're young, and it's a bit easier to do and coordinate when they're older. There's more favorable anatomy potentially as the child gets bigger and grows. You're going to see a larger middle ear and mastoid volume, as well as a more maturity of the eustachian tube problems that these kids often have. The older they are, it's also easier to do better hearing testing and get more reliable air and bone conduction thresholds. Healing tends to be a little bit easier when they're older, and I find that older children just get it in terms of coming in for follow-up and what's needed to be done. So one of the things I tell families and patients is that after a canal surgery, there's still going to be sort of lifelong maintenance needed. And so it's almost like a mastoid, a canal wall down cavity. The epithelium doesn't really migrate and kind of accumulates in there and always will need some degree of periodic debridement or cleaning. And there's really no evidence to suggest that waiting is harmful. And interestingly, some of my patients that have done the best are those that even wait until later teenage years or even to adulthood, after their growth spurt to have a canal surgery. Just circling back a little bit to discuss the nuances of microtia repair. This is going to be coordinated with a plastic surgeon. And so just a couple pointers here in terms of what I do in my practice. So if a family is going to consider doing microtia repair with a rib graft, I prefer to do the atresia surgery afterwards. If they're going to use some artificial substitute such as MedPore, I prefer to do the canal surgery before they repair the outer ear. And the rationale for that is with these artificial tissues such as MedPore, um, if they build the outer ear first with MedPore, then I have to go back in and put the canal. There's a high chance that I may potentially expose the MedPore as part of the surgery. And if that happens, then there's a very high likelihood that that med pore will become kind of infected or contaminated and lead to wound healing issues. Using autologous tissue such as rib, that's really not much of an issue. And so if needed, you can kind of even go through part of the rib graft repair or core a little bit of that out, and it typically heals just fine. So atresia surgery does have a lot of complications. Majority of what we're dealing with is restenosis of the new canal, as well as issues with potentially lateralization of the tympanic membrane and conductive hearing loss, and then issues potentially with drainage. And the pie chart here will just kind of illustrate some of those percentages. So it's a lot. There's a lot of debate around this. Is it still worthwhile to do atresia repair surgery? It's difficult. There's many complications that can occur. The outcomes in terms of hearing are variable, and as I said, there's a high revision rate for some of those problems. Typically, a revision rate, I quote families, is about 1 in 3. But obviously, there's the benefit for having a more sort of natural appearance of the ear. So again, combined with microtia repair and then having an ear canal created, allows for that more natural appearance and sound conduction. Putting in a bone conduction device is technically easier. There's fewer complications, and obviously you put the device in, you pretty much know it's going to work, so the hearing outcome is going to be good and predictable. There's obviously some concern about cosmesis, so some of the older, transcutaneous, percutaneous devices, there's some issues with cosmesis and potentially wound healing and other infectious complications. Obviously, the magnetic devices, the Baja Tract has better cosmesis, but there's maybe an issue with some of the fidelity in terms of high frequency sound. The newer devices are great and kind of are the best of both worlds, but the child has to be at least 12 years old to consider that. And so, as I mentioned before, with some of that data earlier, for children with unilateral conductive hearing loss or unilateral atresia, the use of a bone conduction device in terms of sound localization or benefit and noise is not as, I guess, reliable or good as we would expect. This was a study that looked at hearing outcomes compared between congenital aural atresia repair versus utilization of a bone conduction device or an osseointegrated device. And you can see at the top there, so the canaloplasty surgery, again, a lot of patients can get a good hearing outcome with an SRT or PTA better than 30. But obviously, when you compare that to a bone conduction device, it just can't really match that. So again, almost 100% of patients having placement of a bone conduction device are going to have a significant hearing gain, and there's obviously more variability within atresia repair. In terms of postoperative care, so for those patients that do have atresia surgery with me, I typically will not get the first postoperative audiogram until about 1 month later, and then I do a second one about 6 months later. And after that, its follow-up is mostly kind of yearly. And as I mentioned before, similar to a chronic sort of canal wall down mastoid cavity, these atretic ears after repair do need sort of routine maintenance and cleaning just to kind of clean in a way what is almost like a dead layer of skin that kind of accumulates because that skin just doesn't really migrate out on its own. And if you do the surgery when the kid is young, around 6 or 7, you really got to keep a close eye on them, especially when they get to the age of puberty. They hit their growth spurt, and a lot of times I'll see some bony regrowth and other issues pop up then with stenosis, but there's always a concern for potential worsening hearing loss, which may be related to lateralization of the tympanic membrane and potentially issues with moisture and infection that leads to mucosalization of the skin. So in terms of sort of concluding remarks about aural atresia, every child and their family in terms of their goals is different. Certainly you want to optimize resources in school in terms of preferential seating, utilizing an FM system, and making sure that they have regular speech and language follow-up. And again, then the decision whether or not to amplify or utilize a bone conduction device in these unilateral cases is, again, still somewhat controversial. Obviously, it's a must in those who have bilateral atresia, and I certainly advocate for it if obviously, and encourage it in unilateral cases, but at least objectively, some of the data and research would suggest that the benefits are a little bit more murky, so to speak. Longitudinal follow-up is important, as I kind of indicated before with those patients with cleft palate. You got to monitor their hearing and academic progress, and don't ignore the good ear as well. And so if the good ear has issues, and if they get fluid, ear infections, being maybe a little bit more quick or aggressive placing tubes, or making sure that the care of that ear is optimized. For those who do want to consider surgery, this really depends on a variety of factors, but importantly, it just boils down to kind of what the anatomy is. That's determined by a careful review of some of the structures on the CAT scan. And so we have this J-score grading system, which can be utilized to evaluate whether or not someone is a good candidate. So any score typically better than about a 7 would, in my book, be a candidate, at least objectively, for surgery. Surgery is challenging. If you don't do a lot of this, your outcomes are not going to be great. Even in the hands of a very experienced and skilled surgeon, revision rates will run 25 to 30%. And there's also the nuances of being able to coordinate the microtia repair with plastic surgery. So again, just kind of highlighting that this is really an interdisciplinary problem, team problem. So wrapping up here, I just kind of wanted to highlight some of the recommendations from the American Cleft Palate and Craniofacial Association. So this is a pretty basic guide in terms of sort of audiology care for these patients in terms of their initial assessment and when to follow up, and sort of the timing of that. But again, I think every team should have some degree of a protocol for going about this to ensure compliance and making sure these children have successful outcomes. So that, if I had to say one thing in particular, care of craniofacial patients, again, whether it's atresia, cleft palate, or some of these other syndromic etiologies, it really is all about the team, and make sure you have a protocol to standardize follow-up care. It's important to educate families as well as the team members, and enhance communication to achieve success. So long-term follow-up can be very rewarding. It's one of the highlights of my practice in terms of the pediatric patients I see with craniofacial issues, seeing them have long-term success as they get older. So for cleft palate, again, we discussed that the otologic issue is mostly going to be otitis media with effusion due to the issues that are associated with some of the anatomic problems from the clefting in terms of how it affects the eustachian tube anatomy and how it can open. And so, again, there's some controversy about whether or not tube placement should be kind of more conservative or more aggressive. I personally tend to gravitate towards more of an aggressive approach, and just kind of studying data from my training where we utilize a more aggressive approach, we didn't really see a higher rate of complication in terms of residual perforation or cholesteatoma. And I would say personally that repair of the palate doesn't typically significantly improve eustachian tube function. So these kids will typically have issues with their ear as well into adulthood, and if not throughout their whole life. For congenital aural atresia, again, it's pretty simple in terms of bilateral cases. You need early amplification with a bone conduction device. Unilateral, the evidence is a little bit less clear. I certainly advocate for utilizing some form of hearing device, but the evidence in terms of maybe sound localization or speech and noise is a little bit murky. For some patients, canal surgery can be undertaken. It's a very challenging surgery, but one that I enjoy a lot. And again, it can be for certain candidates based on a variety of factors, in particular the CT anatomy. these candidates, higher the J score will do better. But even despite a good J score and a good surgery, there's a high rate of revision, and some of this happens as they just get bigger. And as I said before, if you're considering about what's going to be the best option or the most consistent option for, hearing improvement, obviously placing a bone conduction device or an osseointegrated device is going to give a more consistent hearing result. So I thank you for your attention. I hope this talk was helpful for you. My email's at the bottom there. If you ever have a question or want to reach out to discuss a patient, always happy to correspond. And thank you again.